We have a fantastic lineup of speakers and presentations prepared for you. First, we'll have a preview and live demonstration of the DIMA app by Prof. Jude Igumbu, a renowned digital health advocate and developer. After that, we're very honored to have Professor Peter Weiser, an expert in our keynote presentation. Before we get started with our session, let's just go through some house rules. So the chat function is available, and let us know who you are, and let's keep that discussion going. We also have a Q&A box at the bottom of the screen where you will be able to type in your questions for the various speakers. There is also a raise hand function, and hopefully we will have enough time to have our speakers address those questions directly. We believe that through collaboration and innovation, we can overcome the barriers to maternal health access and create a brighter future for mothers and infants in Africa. I would like us, without further ado, to move on to our keynote address today. We are so honored to have with us Professor Peter Weiser. He's a distinguished Ugandan researcher, medical doctor, and associate professor of health planning and policy management at Makerere University. Prof, I have to cut it short because we want to hear everything you have to say.
Thank you so much, Ina. What I'm going to do today is basically, I will not speak so much technology, but I'll give a framework maybe in which the technology should be applied to solve the maternal health challenge in Africa. And I'll be presenting most of the challenge. So my name's Peter Weiser, and I both work at Makerere and the Karolinska Institute in Sweden. So I'm talking about breaking barriers, innovating for maternal health access in Africa. And I'd like to emphasize issues of leadership, management, investment, like Julia said, and also health systems issues. That is going to be the outline. I'll give 2 case studies. I'm aware that the time is short, but I want to start here that what is the challenge? And one of the main critical things is that, that Africa's population will about double to 2.5 billion over the next quarter century, just in about 25, 30 years. The population in Africa will double. Africa is still a younger continent with a median age of 19. That means there are many women who are going to be giving birth. Some people call it the youthquake. This youthquake is good as a human capital development, but also it's actually going to be having people give birth. So we expect the number of women giving birth to actually be doubling, because even if the fertility is going down, because women will give birth anyway. And this will put pressure on health systems, and they'll get overwhelmed. And they are not developing in terms of resources, as much as the population is doubling. So yes, we need, of course, these systems like AI and others can promote a lot of planning and self-care, but then also we need to provide services. In terms of the maternal mortality in Africa, I'm not actually going to go over this because Judy has alluded to the numbers. And most important is that we are not doing very well. If we are to achieve the SDGs, we need actually to go much faster and reduce the current maternal mortality by over 80% if we are to achieve the SDG targets. But maternal mortality in Africa is not the same everywhere. Even in countries like Nigeria, where you presented, or Kenya, you find that some places in Nairobi, the maternal death is so small, and then others are so large within the same city and country, and the same for Kampala. So WHO has called this that there is a transition, just like an epidemiological transition, where maternal death and causes of death change. And a new framework has been developed which classifies both maternal death and combines the maternal death with stillbirth and neonatal death. So we cannot separate the mother from the baby. And I'll not go through these stages, but I think the point is different countries, but also in different countries, we have different rates of maternal mortality ratio, but also we also have different causes. I think that is the key. And if the causes are different, then we need more targeting. And I think this is a place, again, where AI tools can actually guide what intervention to deliver in different contexts and what messages to send. This chart just shows the countries of the world and on this transition. And I hope you can see at the bottom of the slide, we show the SDG targets. On the right are countries that have progressed, but on the left are countries that are yet to progress. And you find that almost all African countries, except Tunisia, are actually on the left. So we have still a journey to take in Africa. If we are transitioned to phase 4, where we should be in early phase 4 now, but we are not. And the causes of death have remained the same. So Jude, as you develop the tool, hemorrhage remains an important cause. Postpartum hemorrhage, but of course it can also be abortion. We should also remember to cater for these women who are having abortion and then they get hemorrhage and they die. So how can we get blood? Which places have blood? How can the right blood be got? How can we get to the people who have the right blood group? And those issues. Again, AI tools and others should be able to help in some of these. Can we predict preeclampsia? How about puerperal sepsis? Now we see that for the deaths of children and babies, the progress is much faster, especially children. And I usually say children, we've reduced the deaths because they die from simple things like no hygiene, therefore they get diarrhea. You give them a vaccine or malaria mosquito net, and then you save them. But for a woman who is bleeding, they need a health system which delivers. So one of the things, Jude, which we need to be working on is how can we find the right facility a woman needs to go to, which is nearby and which has the capacity. So I was very happy that you are presenting about which places are performing and maybe have the right interventions and maybe even have the space. Those are some of the issues that we need to be working on. What interventions can save mothers? So this is from a framework that the UN developed. I'm happy to participate in this process. In this process, they say, at least now, almost all women should be able to get antenatal care, 90% of them, and go to antenatal care at that. So we can be showcasing what care are women getting, not just attending antenatal care. 90% should be delivering in a facility. But I think more important, how many are delivering in a facility which has capacity? Can we in the tool be able to show that this facility is good for women, this one is not? I think those are some of the things that we need. How about postpartum care? This is almost not happening. And this is when most mothers and baby die. And of course, for newborn, I'll not go into this, but also critical. So I wanted to demonstrate the challenge of maternal death in Africa, especially the challenge of interventions, by giving you 2 case studies. Back in about 2012, we did a study funded by USAID and PEPFAR in Uganda and Zambia. It's called Saving Mothers Giving Life. And in this study, we reduced maternal death by 44% at population level, which was good. We published this work in this paper in a series. And see what was done. And this is what I wanted you to pay attention to about how we were able to achieve that and what are the challenges. And now, how can we get AI tools into this? Now, for the rest of the slides, I'm going to show you that we did a lot of investment. But despite all the investment, maternal death reduced by just half only. So in 4 districts in Uganda, we added 32 doctors, 163 nurses and midwives. We added hundreds, of community health workers, and we did a lot of mentorship. We did a lot of facility improvements that I'll be showing in the next slides. We actually put transport systems that Jude is talking about, ambulances and referral and stuff like that, and also worked with about 4,000 community health workers. Huge investment. And now see what changed in terms of women, in terms of travel time. The travel time for most of the women who are within 2 hours of a comprehensive emergency care facility improved from different districts from to about 57, the lowest, up to 93, the highest. So most women were able to have access to facilities where they could be saved, but still half of the women died. We also did a lot of other capacity improvement. Look at the rate. The rate is which shows change. The change in availability, 24-hour availability of the facility, availability of power, availability of running water, and availability of emergency care. In some places, availability increased by 200%. So we did everything you could imagine in an African setting. We saved only half of the women, but the other 44, the other half died. In terms of institution delivery and population and the access to C-section. So it is not just enough to take women to facilities. What do they get there? In terms of delivery rate, they increased by about half. But C-section rate C, it increased by 71% in these 4 districts. The same in Zambia. And in terms of access to emergency obstetric care, which actually saves lives, and it improved almost by 60 or 70% for most of these women. So, and in terms of direct obstetric case fatality, that is women who are dying, it reduced by about 45. So with all this investment, still we were not able to get like 80% or 100% of reducing maternal death. But I must say in these districts, we had the highest acceleration in terms of reduction in maternal and in neonatal death after a huge investment. In terms of causes of death, as you can see on the slides, still hemorrhage remained the leading cause of death, but it reduced from where the numbers, as you can see, reduced, everything reduced, but hemorrhage remained. So planning for women who are bleeding is still going to be very important, and also those who are obstructed, and then those who have hypertension in pregnancy, severe hypertension in pregnancy or preeclampsia. So that is case study number 1, which is the Saving Mother Giving Life, a flagship USAID PEPFAR project in Uganda and Zambia. Later it was taken in Nigeria and other countries. A case study 2 is, so those 4 districts were all rural. And in case study 2, I have a PhD student who is Catherine, maybe she's on listening. She's looking at emergency care in the city, looking at Kampala for this question. But Kampala can be Lagos, can be Cape Town, can be another city in Africa, Nairobi. And here she's looking at women who have complications and how they access care. A key take-home message is that we see in Uganda and many African countries that maternal death has come to the city and the places near the city. But these are the same places with a lot of access. Why are women dying when there is so much access? What aren't we doing right? So I just picked a few slides from Catherine's PhD work, which this is a paper she's submitted. And we look at the pathway that the women take for about 500 women. Now, I will not go through each of these pathways, but the take-home message from this is that women almost get lost in the city. Women get lost, they go to facilities, many of which don't have capacity. And even the facilities we think have capacity, eventually have to refer to the national hospital, where women congest and still die. So women, the highest number of women who die in Uganda, they die in the teaching hospital, the National Referral Hospital, Kawempe, because it is congested. Can we have a system that redirects women to places which have capacity and are not congested? So that is one of the messages. And message number 2 is even when these women with complication go to the right facility and they need to be referred to a higher level facility, almost 60% of them first go home. Remember, this is a woman who is bleeding, who has a severe headache, but they first go home to mobilize themselves, many times because they are not prepared, or they don't have insurance, or they have nobody to live at home. So that contributes to the delay, even where there's so much access, because the message I said, they got lost in the city. Can we help women to go straight to the place where they get help and not get lost in the city? Access alone is not enough. So those two case studies leave us with some two key questions. Despite these best case studies where there's been so much investment as in saving mother giving life, maternal deaths was reduced by just 44%. What does it take to reduce it to 90% or 100? And why should women die in the city where transport is not a problem? Even we hope that most of these women are so knowledgeable. What are the issues? We already said that women are so getting lost in the city and stuff like that. Answering these questions can help Africa advance further. And these are some of the places we need to put a lot of the innovations. And for me, I think, like Jude said later, it is a system, not just the health system, but beyond the health system, which includes communities. When we want to do health system improvement, Jude, beyond the AI, which I think is very good, and data, of course, we need to work on other systems. I want you to focus on the red part in my slide, where I say impact. All these interventions will only reduce maternal deaths if we achieve high coverage, that is, women get the right interventions, but with quality. And most importantly, we reach the most vulnerable ones, the poorest, the single mothers, the jobless one, the street women, and so the adolescents. This coverage, now we have high coverage. 90% of the women deliver in a facility, but which facility? Then quality. Quality is the major missing gap, and equity. And I've tried to define quality here. That quality in this formula means that we need to have a package of effective interventions, which every woman should get, delivered by skilled teams, not skilled worker, not one worker, but teams. Might be obstetricians with an anesthesiologist, with a midwife, and a pediatrician, or in some places just midwives, but who are skilled. And then, of course, commodities, including transport. But this must be combined by managing implementation challenges, because you can have all these interventions and skilled teams and commodities like we have in our hospital in Uganda, but women continue to die because there are other things that matter. So I wanted to end with these two slides that demonstrate what is going on in the system, and good enough, Judy has described the system. One, we have the so-called health system building blocks that I think most participants understand. And we might decide that in the governance thing that we need to do these evidence-based interventions. But as we do other components like medicines, information systems, services, human resources, etc., they all must be in place. The AI system be able to show that all these things, hospitals are not running out of commodities, data that is generated is properly utilized, and the human resources that we have are competent, and there is good governance, and women are and families are happy. So it is a complex system, which means how does these innovations help manage this system? So managing complex systems is the missing gap that Africa has. We have expanded the number of workforce, but because even the city where all these things are available, I think a missing component is good design and management of the system. But we see that just focusing on the building blocks is not enough, because some people are poor. Economic issues become important. Social issues like single mothers, mothers with too many babies, and nobody is there to help. The community empowerment is important. And what we do is community workers, but also political leadership and environment. So almost I do give a health system whereby the normal health system we talk about of hospitals and staff is connected to the community and to the leadership and management is what we need. And good enough, I think, Judy's system visualizes this, but can they be put into practice so that we have a seamless system that delivers for mothers? Which leaves me with my last slide, the conclusions and recommendations. That maternal health in Africa is actually improving, but so much more is needed to be done to achieve the SDGs. And the burden of care is most likely going to increase because the population is actually doubling. But so are the options for care. I mean, we have all these options like AI, like private hospitals, like all these new technologies that are being developed. But these need better policy, better leadership, better management, and accountability. I think that all these innovations in technology can actually complement, can bring into. It is no longer just the three-delay model. You know, we have talked about the three model for maternal death, which says delay at home, delay in transport, and delay in receiving care. The third delay is becoming the most critical, and maybe still the first delay, especially related to affordability and stuff like that. But transport systems are there, but they are not well integrated. We need to be working so much on quality of care as I've presented. Prevention is critical because the high fertility and this doubling population means that the burden of care is actually going to get worse. And how do we manage these systems? So we need, like I said before, to ensure that we have interventions that work in different contexts. Where mortality has changed, or in a rural place, you may have a different intervention. In the city, you may have a different intervention. In the city, in the slum, you may need a different intervention. Can AI complement that? This intervention is and their delivery can be guided by better tools like AI, analytics, precision health, community health, and other newer technologies and implementation research. Thank you for giving me this opportunity to present, to leave you that I think we have still a problem to deal with, and all these tools are important, but they must be managed in a way that works for women and families. Thank you so much.
Thank you very much, Prof. Presentation has left me feeling hopeful, yet, you know, it's disheartening but hopeful at the same time. At this stage, I would like to open up the floor for some questions. We have some questions in the chat, but I think, Violet, participants be able to speak to the Prof, or should I read the questions?
Hi, Ina. Thank you. Please, you can go ahead and read the questions.
Okay, thank you. All right, so Prof, we've got a question here from Aristida Bado, who wants to find out what happened to the level of maternal health indicators in the intervention areas of the Saving Mothers and Giving Life project in Uganda after the project. Has the government been able to maintain those achievements? And do you think that this type of project can be replicated on a larger scale in other sub-Saharan African countries?
Yeah, thank you so much. That's a very, very good question. And thank you. This is one of the major limitations of this project, that it was managed by two NGOs with a lot of funding from the US government. They wanted to prove that maternal death could be reduced by 50% in a year, which almost was impossible to do. But after a couple of years, it was demonstrated to be possible with a lot of investment. So I think the number of key messages here, we are not investing enough in maternal death. Even that a lot of investment was not enough. I think the other factors, especially which are contextual to Africa, that our women are there and very poor and maybe uneducated, and just medical tools alone are not enough to save them from dying. We need to do more, maybe social support and also other stuff. Now, did the indicators get maintained? Unfortunately not, because just like a project, many of the things, there was issues with this project. Project design was a bit of a problem. It was a top-down with limited government of Uganda involvement, and especially in terms of leadership and financing. So that was a missed part, which was done better when they were going to scale. But the government also learned a bit from this project. Actually, in this project, they increased the size of doctors in order to maintain them. And when the government learned about this, when they increased in the size of doctors and nurses and midwives in Uganda, and also the number of doctors in health centers and midwives, they took the SMGL standard and took it to national level. So one thing they did very well was in the deployment of health workers and their payment. But despite increasing the size for doctors in Uganda are now quite fair. I think a younger doctor gets about 5 million, which is about $1,500. But the minister is complaining maternal death has not gone down or services have not improved because of what I presented in this slide, that you intervene in one component without intervening in all the components, then systems are complex. You do one component, it has effects on other systems, and we need to manage them. Even when you manage the hospitals, there are things in the community. So, like Jude said, we need an integrated community health facility and maybe other sector system, and how to manage it to work for mothers and women. So both investment, but also training. Most health workers actually are not skilled in many countries to do proper obstetric care, but also in terms of service delivery and managing the system. Can it be replicated? This is a very difficult question, because if countries are not willing to invest and also to manage the system, then they cannot replicate this mode of service delivery.
My apologies, Prof. I think that goes to the other question I wanted to raise, is about the sustainability of these kind of innovations. Even if the results were as were desired, how sustainable are they considering the level of investment required?
Yeah, I think, I always discuss this question of sustainability, that no, we should never sustain anything which doesn't work. So for most governments in Africa, what they are delivering is like 10% of what is needed, and we see the results. So that is so-called sustainable. But how can you sustain a system which is killing women? Like in Uganda, we have reduced a bit, but still about 4,000, 5,000 women die per year. And also over, I think, like 60,000 babies are lost. I mean, we don't need to sustain that kind of system. So we need to tell our government that sustainability, as in is it affordability, is not enough. If we look at health as a human capital development, then we could potentially sustain it because it can save us future costs and produce more. So can we look at health as an economic investment and make the case that way so that they invest more? These same countries are investing a lot in the politics, as you know, in corruption. In Uganda, they say up to 10 trillion shillings is lost per year. That is 20% of the national budget to corruption. Now, I mean, this money, if systems are well managed, could actually save most of the mothers to 80%. So how can we say it's not sustainable when we are not looking at the system in a broader context?
Thank you very much. We have run out of time. I have 2 minutes, and I would like Prof. Waiswa to just, if you have any final words, just your last reflections as we move forward and try to, I guess, deal with this issue.
I think my main one is many women and babies are lost despite even availability of resources. It is the way we manage and deploy these resources. And I think the use of data, if it's combined with management and skills, then we can start with the low-hanging fruits. Because women are dying because there is no glove, because there is no, small commodity, really very small things. They don't need. I went to a meeting of WHO about maternal death. And I said, for most of the problem, we cannot solve them with the conference in the virtual. We need to work on management systems and accountability in our systems. So there are so many low-hanging fruits which we can bridge. Then we move on to the more complex ones, which require more investment. So let's start where we are and do it better, be more accountable. And then also we need to invest more. And I think these technologies have a role, but themselves alone, without combining them with like skills and other things, are not going to give us the optimal outcome. So we need all of them into the system, and they can contribute a lot more. So I welcome Dima because I think it solves a lot of the problem, especially if we can deploy it. And we have opportunities, especially around where most populations are. Most population now are within access, but the access in the wrong care. So we need to use those opportunities better, like cities and areas surrounding the cities. Thank you so much. And thank you for inviting me to make this presentation. Thank you.
Thank you very much, Prof. Iswa. It was so insightful. We are also excited. I think it would make collaborations easier. It seems that people are, the challenges that are being faced across our cities and rural areas seem so similar. And if one could share experiences and make use of tools, one would be able to deal with some of these issues and as you said, Prof, better manage resources. With that said, we would again just like to thank everybody for taking the afternoon to just join us. The conversation, the collaboration continues. DIMA is still open. Please do visit the website at dima-health.com. So all of the information that was presented in the app would also be available on the website. And DIMA is also available on the social medias at dima-health.com. Thank you all so very much and have a good evening and afternoon further.